Hello, bachcho. Hopefully, I'm audible. Let's start the last session now for today, and let's try to complete the appendix. Let's see how much we are able to complete. At least GIT we will be completing. Okay, so pancreatico-hepatobiliary system will be starting then later. If I talk about the next one, beta, as I've told you that we perform a colostomy or a ileostomy. So what is basically an ileostomy or a colostomy, bache? So, for example, if you are making if you are making an external opening beta for the ileum on the abdominal wall, that is called as an ileostomy beta or an ileostomy जो भी बोलो, ठीक है. Whereas if you are making an external opening beta on the anterior abdominal wall, if you are making an external opening for your colon beta, that is what is classically called as a colostomy, right? Both these surgical procedures which are there beta, they are basically done for the passage of feces. Yes, okay. So it can be done in conditions where the patient has lost the complete control over the feces. That means where the anal sphincters of the patient have been damaged. Over there, but in all those conditions, definitely the ileostomy or colostomy can be the permanent procedures. Or it can be done as a temporary procedure like in a Hartmann surgery, where where we do not have to go for an immediate anastomosis. We have to wait for a few days till the infection gets resolved, and in those conditions, till we wait for a few days, beta, we go for an ileostomy or a colostomy. Clear about? Now important is the indications, beta, as I've told you, colorectal cancer. In those conditions, in whichever we have performed an abdominoperineal resection, in those conditions we have to go for a colostomy, or in patients of IBD or inflammatory bowel disease, beta. These are few indications. There are multiple other indications I told you. Now important is beta ileostomy which you do. You have to remember beta, the type of ileostomy that we do is basically, here beta we keep the ileum. Okay, here we keep the ileum actually above the surface. Okay, we do not to keep it at the surface beta, we actually keep the ileum above the surface of the skin. That is what is called as a flush ileostomy. And yaad rakhna, always you have to invert the edges. That means you have to bring out the ileum, you have to definitely turn out the edges beta, and then you have to suture it completely with the skin. Okay, so that is important beta. So the ileostomy that we do, or the ileostomy that we do beta, this is what is actually called as the pout ileostomy. Pout means it looks like pout, na? So definitely it is called as a pouted ileostomy or a pout ileostomy. That means it is nothing else but above the surface, not at the surface. Okay, so that is important. Whereas if I talk about the colostomy, on the other hand, colostomy जो करते हैं बेटा, colostomy is usually done immediately at the surface, right? Colostomy that you do basically beta, it is done at the surface itself. And if you do at the surface, it is called as a flush, right? When we do anything at the surface, that is known as flush. So colostomy which is there, it is done at the surface beta, that is called as a flush colostomy. No issues with this. Next important beta, effluent is what? Effluent is actually the fluid or the substances that are coming out of that opening, right? That is will be called as an effluent. Effluent bolo, excreta bolo, whatever you call it as. The effluent which is there beta, in cases of ileostomy which is there, okay, it is going to be more in amount, whereas in cases of colostomy beta, it is going to be less in amount. You will be like, so why? Reason beta, ileostomy may definitely, this effluent has not gone into the colon. It is directly coming out from the ileum. That's the reason beta, the absorption which would have taken place in the colon has not taken place. And that's the reason the effluent or the excreta is more. Colostomy may definitely beta, the effluent or the the effluent which is there, it has already passed via the colon. So that means a lot of reabsorption would have, a lot of absorption would have taken place. That's the reason the amount of effluent coming out will be lesser. Second important beta, the effluent which is coming out in cases of ileostomy beta will definitely be more of liquid in nature beta. Okay, so definitely it will be liquid in nature, the effluent which is coming out, whereas in patients of colostomy beta, it is going to be semi-solid in nature. Reason beta, as I've told you, in colostomy beta, there will be a lot of absorption of water from that effluent. That's the reason semi-solid material will come out. But ileostomy se bahar agar aata hai beta, so obviously beta, the water absorption would not have taken place, and therefore there will be a lot of water or liquid inside the effluent. Bache. Clear about? Electrolyte disturbances beta, we know that in ileostomy there is more amount of liquid coming out. That's the reason beta, there will be more chances or more risk of electrolyte disturbances over here. In colostomy, definitely beta, there is a semi-solid material coming out, so definitely a lot of water and electrolytes would have got properly absorbed beta. So that's the reason there will be less chances of electrolyte disturbances in a colostomy. Clear to all of you now? These are the important things that you have to remember. Next important picture beta that you are able to see. It is this one beta. What is seen in this picture over here, you are able to see beta, this is called as an end stroma. What we have done, we have pulled out the colon beta and we have definitely turned it out, and then we have sutured it with the surrounding skin beta. So here we have actually pulled out the end of the colon beta and then we have sutured it to the skin. So therefore it is known as the end stroma. This one is what beta, we have pulled out a loop basically of the intestine. As you have pulled out the loop of the intestine, then you are going to cut it out from here beta, and then you are going to actually create an opening. This is what is called as a loop stoma beta. Okay. So when we definitely pull out a loop of the intestine beta, when you are definitely going to pull out the loop of intestine on the surface of the abdominal wall beta, and then you are actually going to create the openings. This will be called as a loop colostomy or a loop ileostomy. Now please remember, in loop colostomy or a loop ileostomy beta, how many openings will be there? There will be two different openings beta. One is going to be the proximal opening, second is going to be a distal opening beta. Okay, but both these openings are connected with each other. Clear hai? Both the openings which are there beta, they are usually connected with each other. Can you see? This is the proximal and distal opening beta. You have to check definitely. Okay, this is can be the proximal, this would be the distal opening, and this is a loop stoma. Next important beta is this double barrel stoma. Double barrel stoma matlab, I definitely beta cut the intestine and then we bring out a proximal end and suture it to the skin. Then we bring out a distal end and we suture it to the skin beta. This is what is called as a double barrel stoma. Can you see? This is a double barrel stoma. Here definitely there is gap beta between the two parts basically, or the two openings. Okay, they are not connected to each other. They are not a part of the same intestine basically. We have to definitely bring out a proximal end and a distal end beta. Hopefully that's clear to all of you. End stoma, loop stoma, and a double barrel stoma beta. This is what is called as a colostomy beta. You can see it is almost at the level of the surface. Okay, therefore I am calling it as colostomy. And we know whenever it is at the surface, it is called as flush. So this is actually a picture of a flush colostomy, right? So that is important. Now if they ask you beta, what could be the complications of the stoma that we have created? Okay, so if I talk about the complications of the stoma beta, so there can be certain early complications of stoma and certain late complications of stoma beta. So first of all, the early complications of stoma will appear within 1 month of the surgery beta. Yes, within 1 month of creating a stoma beta, you will get definitely these complications. What are those? The first one, if the stoma does not receive enough blood supply, it undergoes strangulation and necrosis beta. Next important one, definitely the stoma which is there beta, it gets pulled inside. The intestine which is there, it may get pulled inside. That is called as retraction. Or definitely beta, around the stoma, as the fluid is there beta, this fluid or this effluent may come in contact with the surrounding skin, and definitely beta, there can be damage to the skin. That is called a skin excoriation beta. Okay, then further definitely the patient may also develop dermatitis also beta. There can be inflammation of the skin. The patient may have abscess beta at the stoma site due to infection. There can be abscess at the stoma site. The patient may have a lot of fluid and electrolyte imbalance beta. I've told you in ileostomy there will be more chance. The patient may have a fluid and electrolyte imbalance or disturbance. Next important, if I talk about beta, the late complication which usually happens after 1 month of the stoma creation beta, and these late complications can be, one of them is prolapse. What is prolapse? Here definitely the stoma which is there or the intestine which is there beta, it is coming outside, it is hanging outside, right? If it gets pulled inside, it is retraction, which is an early complication. If it hangs outside, it is prolapse, which is a late complication. Next important, there can be a parastomal hernia. You are able to see beta around the stoma. As you have created a stoma beta, definitely the wall of the anterior abdominal wall of the patient beta becomes weaker, and as the anterior abdominal wall of the patient becomes weak beta, you are able to see the herniation around the stoma. That is called as a parastomal hernia. Next important, there can be stenosis. That is narrowing of the stomal opening beta. Okay, the stomal opening itself can get narrow or it can get completely obstructed as well. If they ask you which is the most common complication of an ileostomy, so the most common complication of an ileostomy is nothing else but the skin excoriation beta. Okay, yaad rakhna, the most common complication of an ileostomy is the skin excoriation. Reason, we know beta in ileostomy there is a lot of fluid effluent which is there, and that fluid will come in contact with the surrounding skin beta, and that is the reason this patient may have a skin excoriation. Whereas if they ask you beta that what is the most common complication of a colostomy, the most common complication of a colostomy beta is going to be a parastomal hernia. The most common complication of a colostomy is going to be a parastomal hernia. Hopefully clear to all of you. Now important is beta, if they ask you the first picture which is there beta, this is actually a skin excoriation that you are able to see. The second picture which is there beta, it is nothing else but a necrosis which is there. And yaad rakhna, necrosis is not only the early, but rather the earliest complications. Right? Necrosis which is there beta, it is basically the earliest complication of a stoma. And the last one which is there beta, it is nothing else but a parastomal hernia. Okay? So these are the complications that you are able to see in the picture beta. Now let's talk about the next condition, a small one, that is known as mesenteric cyst. What is cyst? A sac which contains fluid is known as a cyst. So in the mesentery, if there is collection of fluid beta, and that leads to formation of a cyst, that will be called as a mesenteric cyst beta. Now in patients of mesenteric cyst, there's a classical triad which is seen. So do remember the name of that triad, important. So the mesenteric cyst ka triad beta is classically called as the Tilloch's triad, right? The triad in a patient of mesenteric cyst is classically known as the Tilloch's triad beta if I talk about. And Tilloch's triad mein baat kare to what will be the features? First of all beta, due to the cyst, definitely in the abdomen when you palpate, you will be able to feel a soft fluctuant swelling beta, right? The patient may have a soft fluctuant swelling, and it is usually seen in which area? The soft fluctuant swelling due to the cyst, it is usually seen in the umbilical area beta. Okay. Second important feature that you have to remember, that the swelling which is there beta, the swelling is going to be freely mobile beta, and where it is going to move, understand. For example beta, this is the mesentery. So this is the swelling over here. Okay, this is the cyst which is developing from the mesentery. You can actually move the cyst beta in a direction. You can move the cyst in direction of the mesentery or direction perpendicular to the mesentery. So if this is the mesentery, you can move the cyst like this. That is direction perpendicular to the mesentery beta. Clear hai? So that is important. Second feature, that the swelling which is there beta, it is actually going to be freely mobile, and this swelling which is there, it will be moving in which direction? In the direction perpendicular to the mesentery. Okay, not parallel. It will move in a direction perpendicular to the mesentery. Third important feature that you have to remember beta, and that is, if you percuss definitely the abdomen all around the mesenteric cyst beta, or all around the swelling, basically you will be able to get a zone of resonance basically, right? So there will be a zone of resonance beta all around the swelling. These are the three features in the Tilloch's triad of a mesenteric cyst. Okay, soft fluctuant swelling in the umbilical region. On palpation, the swelling is freely mobile, and it is mobile in the perpendicular direction to the mesentery. Third important, zone of resonance all around the swelling. Now please remember beta, there are two types of mesenteric cyst basically. The first one that you are able to see beta is called as a chylolymphatic cyst, right? What is there? Here definitely beta, there is a cyst which is there. It is basically due to collection of a lot of lymphatic fluid inside the mesentery beta. When there is collection of a lot of lymphatic fluid in the mesentery, that has led to collection of this cyst beta. This is what is called as a chylolymphatic cyst, and obviously this is going to be a common type of a mesenteric cyst. Next one is this one beta. Here also you are able to see a cyst beta, but this is basically due to collection of tissues. Okay, it is basically when the intestinal tissues which are there beta, they get trapped, and that leads to formation of a cyst beta. So this type of a cyst is known as an enterogenic cyst. This is classically called as the enterogenic cyst. Okay, that is important. Chalo. So let's talk about the two types of cyst beta. The first one which is there, as I told you, it is known as a chylolymphatic cyst beta. The chylolymphatic cyst which is there, it mainly contains a lymphatic fluid inside the cyst or the mesentery beta. Investigation of choice is a CECT abdo beta. Investigation of choice has to be a CECT abdomen. Treatment, if they ask you, treatment has to be removal of that cyst only, and if I do only a removal of that cyst, it is known as an enucleation. Removal of the cyst only is called as an enucleation beta. Next type of a cyst is an enterogenic cyst. By the name it is evident. Entra means intestine. So enterogenic cyst, it contains the intestinal or the bowel elements beta inside it. Investigation of choice is again the same, that is a CECT abdomen. But this time beta, the surgery is not going to be the enucleation. Rather, here we have to remove that part of the intestine beta which is having this enterogenic cyst. So if I am going to remove the part and I'm going to join the remaining part, that will be called as a resection and anastomosis. So here beta, we have to go for a resection and anastomosis now. Clear about? That is important. So this is what is you have to remember about the mesenteric cyst. Now another short topic beta, and that is nothing else but a short bowel syndrome. Now what is a short bowel syndrome? We know beta, the small intestine which is there, the length of that small intestine is around 6 to 7 meters. But due to whatsoever reason beta, we had to cut out majority part of the small intestine. and only less than 2 meters of small intestine will be left behind beta. Okay, only a small segment of small intestine is left. That condition is what is known as a short bowel syndrome. Obviously, if there is a small segment of intestine left, there will be problems with absorption, right? There will be malabsorption. That is important. If I talk about beta, a short bowel syndrome in a patient, short bowel syndrome is nothing else but when the length of the small intestine which is left behind, when the length of the small intestine which is left behind beta is how much? It is even less than 200 centimeters beta. It is even less than 200 centimeters, that is less than 2 meters beta. 2 meter भी intestine नहीं बिची है. So what will be the causes in this patient beta? The causes in this patient will be either a superior mesenteric artery embolism. I have told you that superior mesenteric artery embolism is the most common cause of a mesenteric ischemia. And due to mesenteric ischemia, there will be strangulation and necrosis of the intestine. So if there is necrosis of intestine, you have to cut out the majority part of the intestine. And that's the reason the patient may have a short bowel syndrome as a complication. Next, Crohn's disease. We have discussed that Crohn's can involve any part of the GIT. It can involve a very long segment of GIT beta. That's the reason we have to cut out that part. And even in patients of cancers, we directly do hemicolectomies or colectomies, right? Along with that, if the small intestine is involved, we have to resect majority part of that intestine. That's the reason. If they ask you beta, what will be the clinical features? As I've told you beta, if there's a very small part of the intestine left behind, there will be malabsorption beta in the patient. There can be osmotic diarrhea, because if the food doesn't get absorbed, the highly concentrated food will attract water, causing osmotic diarrhea. The patient will have weight loss beta because absorption nahi ho pa raha, and there will be multiple nutritional deficiencies beta in the patient. If they ask you what should be done in this patient beta, obviously as the patient is having malabsorption, so obviously we have to keep the patient on a long-term TPN. What is TPN? Total parenteral nutrition, right? We have discussed now in total parenteral nutrition, one of the indication was what? One of the indication was short bowel syndrome. So this patient should be kept on a long-term total parenteral nutrition. But can we keep this patient on a lifelong total parenteral nutrition? No beta. We should not keep the patient on a lifelong TPN. So उसके लिए क्या करना है? So beta, we have to do a surgery. So only till surgery we have to keep the patient on a TPN. Now what is the surgery that we can do? One is called as a Bianchi procedure. What is that Bianchi procedure? Let's try to understand. See, we have beta, this is the small intestine which is left behind. Okay, this is the small intestine, for example, which is left behind. What we will do, we will actually cut out the small intestine beta, and after cutting out, we now have two small intestines. We are going to definitely create lumen out of them beta. दोनों से एक lumen बना लो. And once you definitely create lumens out of them, definitely now what are we going to do? We are actually going to connect both these ones beta in serial manner. Okay, you are going to do an anastomosis beta like this. Obviously, you will be like, sir, the diameter of the intestine is less. Yes, the diameter of intestine is less, but at least the length of the intestine has been restored, right? And that is what we wanted basically, right? So please remember beta, here we can do a resection. First of all, we can cut the intestine into two halves, then we can create two tubes out of it, and we can connect them in a serial manner beta. That is the Bianchi procedure. Second one which is there beta, it is a step basically, that is a serial transverse enteroplasty. So step or the serial transverse enteroplasty mein kya karte hain, understand. Here beta we use staplers basically, and we are going to apply the staplers beta in the intestine. But in which manner? In this kind of manner beta. We are going to apply the staplers in this manner. Now what is going to happen due to these kind of staplers beta? As we have applied the staplers in a zigzag manner beta, what will happen now? Now the food is going to travel via the intestine, but the food is going to take longer time for the travel. So definitely the transit time for the food is going to be more. And if the transit time for the food is going to be more beta, there will be better absorption from the food. Clear about? So this is the another surgery beta that we can perform. Clear? Next condition now we have to talk about beta is nothing else but called as a rectal prolapse. As I've told you beta, what do I mean by prolapse? Prolapse beta means something is hanging out. And here what is hanging out? The rectum is hanging out. Yes. So now for example, this is your anal canal beta, and here we have the rectum above the anal canal, right? What has happened over here? Here definitely beta, the rectum has started hanging outside the anal canal. Yes. Here definitely the rectum is hanging outside the anal canal beta, as you can see the picture over here. Can you see? Here you can see the mucosa of the rectum is actually hanging outside the anal canal, and this is basically called as a partial thickness rectal prolapse beta, right? When only the mucosa hangs outside the anal canal. In the second picture you are able to see beta, here the whole rectum of the patient is hanging outside the anal canal. That is mucosa, submucosa, muscularis. All the layers are present of the rectum beta in this prolapse. ठीक है. So such kind of a prolapse beta will be called as a full thickness rectal prolapse, right? Such a rectal prolapse will be called as a full thickness rectal prolapse. Clear about this is what is a prolapse beta. You might have seen genital prolapse also in gynae, na? Similar to that. So rectal prolapse which is there, what are the risk factors to it? For rectal prolapse mein beta, the most important risk factor is recurrent bouts of diarrhea. So if a patient is having more than 20 episodes of diarrhea in a day beta, obviously due to that what is going to happen? If the patient is having recurrent bouts of diarrhea beta, due to that there will be a constant pressure on the patient's perineum beta, and due to that the patient's perineum or the perineal muscles are going to become weaker or lax beta, and that's the reason definitely the patient will have a higher risk of rectal prolapse. Next, if the patient is having an obstructed labor beta, if the patient is having an obstructed labor, due to obstructed labor what happens beta? The head of the baby stays inside the vagina for a longer duration of time. Due to that there is a constant pressure on the perineum beta, and that is the reason why the perineal muscles of the patient will become weaker or lax. ठीक है, तो याद रखना either recurrent bouts of diarrhea or obstructed labor, दोनों की वजह से the perineum of the patient will become lax or weak, and that is the reason why the patient may develop the rectal prolapse, because the perineum will not be able to hold the rectum in place. If they ask you about the two types of rectal prolapse, first is partial thickness rectal prolapse beta. In partial thickness rectal prolapse, what only hangs out beta? Only the mucosa of the rectum is going to hang out. So in partial thickness rectal prolapse, there is involvement of the mucosa only, right? There is involvement of the mucosa only beta. We know that partial thickness rectal prolapse will be more commonly seen in which age group? You remember that partial thickness rectal prolapse beta, it is usually more common in children. Okay, because in children beta, at least the tone of the muscles will be somewhat better. Okay, even if the muscles have got weaker, at least the tone will be somewhat better. But in elderly patients, the muscles have become weak beta, they will lose all the tone. So therefore they will have more chances of full thickness rectal prolapse. Clear about? So that is important. If they say beta, if the child has come to you with a partial thickness rectal prolapse and it is the very first time beta or the very first episode, then we have to just push back the rectum beta. We have to just push back the rectum with our fingers, okay, into its original place, and that is called as a digital repositioning. You can call it as digital repositioning or manual reduction, whatever you say. Okay, you have to do that. But if the child has come to you beta with a recurrent case, and if there is a recurrent case of rectal prolapse beta, yaad rakhna hai, recurrent cases of rectal prolapse mein, we have to perform a perineal surgery beta, and that perineal surgery is known as a Thiersch wiring. What is that? We'll talk about it. It is known as a Thiersch wiring beta. So let's try to discuss it. So the Thiersch wiring that we do basically beta in a recurrent partial thickness rectal prolapse in a child, it is going to be this one. See over here what we have created. We have basically created a tunnel beta around the rectum, sorry, around the anal canal beta in the perineum. And once we have created this tunnel around the anal canal beta, okay, in the perineum, what we have done, we have actually passed beta a wire. Okay, we have actually passed a wire from this tunnel beta around the anal canal. Now what I'm going to do, I'm going to pull this wire beta. So as I pull the wire around the anal canal beta, the anal canal of the patient is going to become narrow. And as the anal canal of the patient becomes narrow beta, now from this narrow anal canal, can the rectum go outside beta? No. But one thing you have to keep in mind beta, that always remember that when you tighten the anal canal, always insert your finger and tighten. Reason, you should not completely close the anal canal. The patient will not be able to pass the feces after that otherwise. Okay? So that is important beta. You just have to narrow down the anal canal so that the rectum is not able to hang out. Okay? This is what is called as the Thiersch wiring beta. Next important is a case of full thickness rectal prolapse. If I talk about a full thickness rectal prolapse, I have told you here what will be happening. Here there will be involvement of all the layers beta. Here there will be involvement of all layers basically. Now important is if they ask you, it is more commonly seen in which age group? We know beta that full thickness rectal prolapse is more commonly seen in elderly patients or even in the adults. Adults may whom? More commonly females beta. Elderly patients it can be seen in males also and females also, but in adults mainly in the females. Why beta? Reason definitely, if a female had an obstructed labor, she may have a high chance of genital prolapse or even a rectal prolapse after the delivery, right? That is important. If they ask you beta, in cases of full thickness rectal prolapse, what will be the surgeries beta? Yaad rakhna, in a full thickness rectal prolapse, there are two options with us. Either we can go for a perineal approach surgeries or we can go for an abdominal approach surgeries. And the question has been asked in your examination that which among the following is not a perineal approach surgery? Ye question tha. ठीक है, तो लेट्स टॉक अबाउट दिस फर्स्ट. So the differences between a perineal approach surgeries and abdominal approach surgeries बेटा. याद रखना which surgeries will be more complex बेटा. We know that the abdominal approach surgeries are going to be more complex beta. Perineal approach surgeries will be less complex. Reason, if you are going to operate from the abdomen beta, you have to go from the abdomen till the rectum, you have to pull up the rectum, and there are so many organs over here. That's the reason beta it is going to be more complex. Perineal approach surgery, definitely it will be much easier to do. Complications, obviously beta, the surgery which is more complex will have more complications with it. So abdominal approach surgery will have more complications, but the perineal approach surgery will have less complications. But beta, what is the funda? That when I do abdominal approach surgery, I pull up the rectum properly, I fix the rectum properly with the help of a mesh beta, so that the chances of recurrence are very, very less. Okay, so though abdominal surgery is definitely more complex, more complications, but the chances of recurrence which are there beta, they will be less. But in a perineal approach surgery beta, the chances of recurrence are going to be more. Okay, in a perineal approach surgery, the chances of recurrence which are there, they are going to be high. If they ask you about the age group beta, now please remember, if they ask you about the age group, perineal approach surgery which is there beta, it is usually preferred in elderly patient. Okay, perineal approach surgery which is, it is usually preferred in elderly patient, whereas abdominal approach surgery beta, it is preferred in a young patient. You will be like, so why? Reason beta, perineal approach surgery may definitely, as I told you, it is less complex surgery. There will be less complications. We know already in elderly patients beta, they will be suffering from so many diseases. So that is the reason in elderly patients we want a less complex and a less complicated surgery. That is the perineal approach surgery. You will say recurrence beta. Now Baba has come to us at 65 years of age. What is the guarantee that Baba will come to us in the next 5 years with a recurrence? Chance is very low, right? Practically speaking, that's important. That's the reason beta, perineal approach surgeries are preferred in elderly patient. But in a young patient beta, he has to go for work every day, obviously he has to do gymming at times and all of that beta. Okay? So in a young patient, even if the surgery is complex, his body will be able to handle that complex surgery, but the chance of recurrence should be less. Okay? If they ask you what are the examples now, remember the names. The perineal approach surgery that we have seen already in a partial thickness rectal prolapse, and that was Thiers-Schweiring beta. So Thiers-Schweiring is a perineal surgery. The other repairs that we do beta, one is called as the Delorme's repair. One is known as a Delorme's repair. The second one which is there beta is known as an Artemius repair. So Thiers-Schweiring, Delorme's repair, Artemius repair, these are going to be the three types of surgeries beta that you need to remember. These are the perineal approach surgeries. If they ask you beta about the abdominal approach surgery, here you can see beta the abdominal approach surgery which is there. ठीक है, एक बार देख लो यहाँ पे. This is the surgery beta. You have pulled up the rectum from the abdomen, and now what you have done, you have basically fixed up the rectum beta with the help of this mesh over here. So as you are going to fix the rectum over here with the help of a mesh, obviously the chance of recurrence is going to be very, very less beta. The fixation will be much better over here. And as you are fixing the mesh, as you are fixing the rectum beta, we know fixation is called as pexy. So therefore this surgery that we did beta is known as a Wells and a Repstein's rectopexy. This abdominal approach surgery is known as a Wells and a Repstein's rectopexy beta, one surgery. Now sometimes what happens beta, due to a full thickness rectal prolapse, now the rectum of the patient gets elongated. So due to that, what we do, we actually have to cut out some part beta, we have to amputate some part of the rectum. Okay, and then after that we have to do a fixation. Now that surgery where we amputate some part of the rectum beta, it will be called as the Frickman and the Goldberg resection rectopexy beta. It should be called as the Frickman's and Goldberg resection. Resection means we are cutting out some part. It will be known as the Frickman and resection. Frickman's and the Goldberg resection rectopexy. Clear to all of you? These are the things that has to be remembered. Next important beta, if they ask you what can be the complications of surgery. Now, if I talk about the complications of surgery beta, the most common complication of these surgeries beta, whether you go for a perineal approach surgery or an abdominal approach surgery, abdominal approach surgeries will have more common complications beta. Okay? So please remember bache, that the complications of this surgery, if they ask you, the most common complication is we may injure the nerves beta in the perineum which are actually supplying the urinary bladder, due to which the urinary bladder beta will not be able to contract, and therefore there will be retention of urine. The most common complication of this surgery beta can be urine retention. Okay, the most common complication after this surgery could be urine retention beta. Apart from that, the other side effects or the other complications could be the patient may have impotence beta, that is inability to get a penile erection, There can be a chance of recurrence, more commonly seen with perineal approach surgeries, and there can be a chance of incontinence. Reason, you're operating in the around the anal canal beta. You may damage the anal sphincters, leading to a anal or a fecal incontinence. Clear about that? Is important. Next important beta, if I talk about, is the pilonidal sinus, basically, okay, also known as Jeep driver's bottoms disease. Now, when I talk about pilonidal sinus or a Jeep driver bottoms disease beta, in this condition, what is going to happen? Understand. We know beta that this is the anal canal of the patient, and this is basically the natal cleft beta. Yes, the middle part, and this is one buttock, this is second buttock. Okay, so that is important. Now here what happens beta, basically here there was an infection beta in the perianal gland. Now that infection of the perianal gland led to formation of an abscess, and that abscess which is there beta, it ultimately ruptures, and as that abscess ruptures beta, now what is going to happen, there will be formation of a one-way connection with skin, and as the abscess ruptures, definitely there is drainage of all the pus, and now you can see beta, there is formation of one-way connection with skin. I hope all of you are quite aware, one-way connection with skin is known as a sinus, and this sinus beta will be formed basically beta in this area over here. Okay, that means in the midline area beta, called as a butt crack. Butt crack jo hota hai na, in that butt crack beta, in the natal cleft, this sinus will be formed. Okay, it will be draining pus, and it will cause a lot of perianal pain. It is seen in which patients beta? It is seen in those patients definitely who maintain poor hygiene in that area, and second, who have a hairy gluteal skin. Hairy gluteal skin actually will lead to a poor hygiene. And along with that beta, those patients who are going to have prolonged sitting beta, that means those who drive trucks or jeeps beta for almost longer distances. Okay, so that's the reason beta, as it is more commonly seen in truck or jeep drivers, it is also called as jeep drivers bottoms disease. Clear about? So if they ask you pilonidal sinus or the jeep driver bottoms disease beta, the most common site, as I've told you, it is basically between the two buttocks, and that area is known as the natal cleft. That area which is there beta, it is known as the natal cleft. If they say what will be seen, as I've told you, here you will be able to see sinus beta in the hairy gluteal skin. Yes, there will be sinus in the hairy gluteal skin, and from that sinus, what will be coming out? There will be a serous or a pus discharge which will be coming out. There will be a serous or a pus like discharge coming out. Clear to all of you? Here you are able to see beta the picture classically. This is the sinus beta. These are the sinuses definitely which have developed in the natal cleft. This is what is called as a pilonidal sinus. Now what can be the treatment of this condition beta? You can do definitely a MRI for the investigation beta. If they ask you what is the investigation, so please remember, for the purpose of diagnosis, you can do a clinical diagnosis, and then to see the extent, you can go for a MRI. I've told you na, perineal structures may definitely the best is always a MRI. After that beta, once you have assessed everything, once you have confirmed it is a case of pilonidal sinus, then what we can do, one of the treatment option is, we can actually resect this pilonidal sinus completely beta, and that is done by a procedure known as the Bascom surgery or a Bascom's procedure. Previous year question of your exam. Okay, so we have to go for a surgery beta, but along with that we have to give antibiotics so that the infection will heal. Second, if there is an abscess, now it is in the stage of abscess still, then we can go for an incision and drainage. But if it has already progressed into the stage of a sinus, then the definitive management which is there, beta, as I've told you, it's called as which surgery? It is known as the Bascom surgery beta, or the Bascom's procedure. It is known as the Bascom surgery or the Bascom's procedure. Apart from that beta, if they ask you what is the other thing, so it is this one beta. Can you see, we have discussed about this flap over here. What is this flap? We have basically taken this flap beta from this side. ये जो side है, यहाँ से flap लिया जाता है, and we are actually going to shift the side of this flap, right? We are going to rotate the axis of this flap. So basically beta, we actually had a sinus in that area. We had to close that sinus, and that's the reason beta, we have just shifted the flap over here. And as we are going to shift the flap over here, what we are going to do in this area, we are just going to bring those sides together, and we are going to suture it off. Now this flap that we have created beta, it is which kind of a flap beta? The shape of this flap is rhomboid. So this is classically called as a rhomboid flap beta. I've told you 9 flaps. This is classically known as the rhomboid flap, also known as the Limburg flap beta. This is what is called as the rhomboid or the Limburg flap. They have given a picture of this flap beta, I told you in the previous year also. Okay, the rhomboid or the Limburg flap was given in the picture, and they asked that this is actually used for which condition. Ulta pucha gaya tha. So please remember, we know beta the rhomboid or the limbar flap is basically used for the treatment of pyrenoidal sinus beta. Done with this. Now let's talk about another condition beta. And that next condition which is there is nothing else but ARM beta. What is ARM? Anorectal malformation. Now when I talk about anorectal malformation, that means the baby who was there definitely in the fetal life had some defect beta in the anal canal or the rectum while development. And those together, all those problems, all those defects together beta will be classified under ARM or the anorectal malformation. I hope all of you are quite aware that we have discussed that anorectal malformation is associated with which group of anomalies. These group of anomalies can occur together in a single child, right? And those anomalies beta we have discussed are classically called as the factor anomalies, right? V for vertebral defects, A for anorectal malformation, C for cardiac anomalies, okay, TE for tracheoesophageal fistula, R for renal agenesis, L for limb defects. बराबर है उसमें से I've told you cardiac anomalies are the most common in a child, but yes, anorectal malformations can occur along with them. ठीक है. Now here you have to remember beta the various types of anorectal malformations क्या हो सकते हैं. The anal canal of the patient does not develop. That is called as the anal atresia. Rectum of the patient will not develop. That is rectal atresia. Here, the anal canal of the patient develops beta, but it does not fuse with the skin. Okay, and that's the reason definitely beta the patient is having what? A gap between the anal canal and the rectum, and that is what is called as an imperforate anus, because there is no opening on the anal canal. That is what is known as an imperforate anus. Or there can be actually abnormal connections, that is fistulas, between the anal canal and the GI tract of the patient, right? That can be called as a recto-bulbar fistula in males, where there is a connection between the rectum and the bulbar urethra of males. Or it can be a recto-vaginal fistula, where there is a connection in females between the rectum and her vagina, right? So multiple kind of anorectal malformations can be there. याद रखना बेटा, the most common type if they ask you, you tend to mark it as imperforate anus, but नहीं है. Please remember beta, the most common type of anorectal malformation in males beta has to be the recto-bulbar fistula. The most common type of anorectal malformation in males is the recto-bulbar fistula, whereas in females beta is the recto-vaginal fistula. In females beta it is going to be the recto-vaginal fistula. No issues with this. Apart from that, the other defects which are there beta, obviously those other defects could be the patient may be having an imperforate anus, the patient may have rectal atresia, the patient may have perineal fistulas, okay? Multiple other ARMs can be there. If they ask you beta, if a patient is basically having anorectal malformation, so what should be the first line investigation for him? The first line investigation for this child beta is going to be this X-ray over here. This has come in your FMG June 2021 exam earlier, and they have basically asked the diagnosis also, and in one of the exams they asked the name. याद रखना, you have to hold the baby upside down. Yes, you have to hold the baby's legs. टांगे पकड़नी, उल्टा पकड़ना है बच्चे को. This is what is classically called as an invertogram. This X-ray which is there beta, it is known as an invertogram. Now on that invertogram you are able to see beta that we have kept this metallic marker over here. This is what we have kept now. It is either a coin or a metallic marker. Why? Because here beta the baby's anal opening is not found. Yes, it is a case of imperforate anus where the baby's anal opening is not found. So at the site where the anal opening should have been present, over there we keep definitely beta this metallic marker, and then we actually calculate the distance between the tip of the gas shadow and the metallic marker. Q, we have to calculate the distance between tip of gas shadow and the metallic marker to know beta that there is how much gap between the anal canal and the tract which have developed. Okay, so that will tell us basically whether it is a high anorectal malformation or a low anorectal malformation. Kaise? If the gap is more than 2 centimeters beta, then it is a case of a high ARM. If the gap is less than 2 centimeters, that means it is a low ARM. Okay? So yaad rakhna, the first line investigation that we do in patients of anorectal malformation, you have to remember it is known as an invertogram. Okay, it is known as an invertogram. It is usually done beta not in the first 24 hours, it is done after the first 24 hours beta, not done in, just cut it and write down, done after the first 24 hours beta. Yes, it is usually done after the first 24 hours of life beta. Okay, and as I told you, a metallic marker will be placed at the anal opening or a suspected anal opening, and then you have to measure the distance beta between the tip of the gas shadow and the metallic marker. If the tip of the gas shadow and the metallic marker has a distance of less than 2 centimeters, then it is a case of a low ARM. And if the distance between both of them is going to be more than 2 centimeters, then it is going to be a high ARM. So here here the invertogram which is there, beta, it is usually a case of imperforate anus. How does the imperforate anus looks like? So the imperforate anus looks like this. Can you see any anal opening, beta, in the baby over here? No. Okay, there can be a dimple, but there is no anal opening as such, beta. Okay, so this is a classical picture, beta, which is given of an imperforate anus in the child. Even the invertogram is showing the same thing. Clear about? Now, if they ask you what is the investigation of choice, see, invertogram can be the first line investigation, but X-ray cannot diagnose, right? So, beta, investigation of choice. I have told you which is the best radiological investigations for perineal structures. It has to be the MRI. So, the investigation of choice for this anorectal malformation has to be the MRI, that is magnetic resonance imaging. So, the investigation of choice to confirm the diagnosis has to be MRI. Once you have done MRI, you have diagnosed which anorectal malformation it is, okay, what is the defect exactly, everything. Then you will move for the treatment. Now, beta, treatment is easy. There is only one surgery, beta, that is basically a repair of the anus and the rectum together. That is called as a posterior sagittal anorectoplasty. Yes, whatever is the anorectal malformation, beta, whatever we are going to do a repair, basically, that will all be considered under one single surgery known as a PSARP. Posterior sagittal anorectoplasty. Okay? So please remember that this surgery which is there, beta, it can be immediately done if a patient is having a low ARM. Why? Because low ARM agar hai, beta, that means the gap is very, very less. That means the distance between the skin and the tract which is there, it is very less. You can immediately go for a connection, beta. But if the gap is more, that means it is a case of a high anorectal malformation. I cannot pull. So in that condition, what we do? In that condition, beta, when it is a high ARM, we actually bring out the colon, beta, on the anterior abdominal wall for few days. And here in the few days, beta, this anal opening which is there, or the rectum which is there, it is going to grow. And once it grows, definitely, beta, then we can bring inside the colon and we can do a anastomosis later. Okay? So for first few days, beta, till the anal canal or the rectum is growing, we actually have to do a colostomy in the baby of a high anorectal malformation. Clear about? So in a low anorectal malformation, we can directly go for a surgery. And that surgery which is there, beta, as I told you, it is known as a posterior sagittal anorectoplasty. It is known as a posterior sagittal anorectoplasty. Okay? That surgery which is there, beta, it is known as a PSARP. Whereas high anorectal malformation which is there, beta, here you have to initially go for a colostomy, which is here we have to go for a initially colostomy for a few days. We wait for the anal canal of the rectum to grow, and then followed by that we have to go for the posterior sagittal anorectoplasty. Clear to all of you now? Now, the next topic which is there, beta, that we have to talk about is nothing else but hemorrhoids or piles. The next topic that we need to talk about, beta, is nothing else but hemorrhoids or piles. Shall I? Chalo. Hopefully you have written. If I talk about hemorrhoids or piles now, beta, we know what are hemorrhoids or piles, beta. It is nothing else but when the pressure inside the rectal vessels are going to increase. Sorry. When the pressure inside the rectal vessels is going to increase, beta, and those rectal vessels are going to dilate, and they are going to become tortuous and form a mass, beta, right? When the pressure inside the rectal vessels increase, when these rectal vessels dilate and they become tortuous and form a mass, beta, that is what is called as hemorrhoids, basically. Okay? Now, as the pressure inside these rectal vessels is very, very high, what is going to happen? If you apply more pressure, like for example, a person who is having constipation, beta, or a person definitely who is definitely straining too much, in that patient, beta, if you increase the pressure on these hemorrhoids, obviously, beta, these vessels which are dilated already, they are going to rupture and they will cause a lot of bleeding, beta. Okay, they will cause a lower GI hemorrhage. We know hemorrhoids is the most common cause of lower GI hemorrhage, and the patient will come to you with a complaint of bleeding per rectum. Okay? So hemorrhoids which are there, beta, they are nothing else but dilated and tortuous rectal vessels, beta, which may bleed. Not always bleed, beta, which may bleed. Now, important is the clinical feature. I have told you, beta, what is the most important risk factor? The most important risk factor is constipation over here. Because due to constipation, the patient keeps on applying a lot of pressure, beta. The patient keeps on straining too much. So, history of constipation will be very classical. Along with that, beta, the patient will have bleeding per rectum, but it will be painful or painless. So, yaad rakhna, beta. If I say, for example, this is the rectum of the patient and this is the dentate line. Any hemorrhoid that is above the dentate line, beta, is called as an internal hemorrhoid. Any hemorrhoid which is below the dentate line is known as an external hemorrhoid. Yaad rakhna, now the area above the dentate line, beta, will be supplied or will be innervated by the hypogastric nerve plexus. And that hypogastric nerve plexus, beta, has no pain fibers only. So that's the reason all your internal hemorrhoids are going to be painless. Whereas the area below the dentate line, beta, it is usually innervated or supplied by the branches of pudendal nerve. Pudendal nerve definitely carries pain fibers, beta. So if there is any hemorrhoids below the dentate line, that is the external hemorrhoids, those are going to be painful. Please remember, more commonly we have the internal hemorrhoids. That means majorly, beta, the hemorrhoids are going to be painless. Okay, so yaad rakhna, the hemorrhoids which are there, the common presentation which is there, they present to us with a painless bleeding per rectum. They present to us, beta, with a classical complaint of painless bleeding per rectum. And this bleeding which is there, beta, it is described as what? So here the vessels are rupturing, beta, and then the patient is bleeding. So there will be massive bleeding over here, beta, and this bleeding which is there, it is usually described as splash in the pan appearance. Okay, that is called, this is usually referred to as, beta, the splash in pan appearance. Okay, the patient is going to have a painless bleeding per rectum, beta. That is important to be remembered. Now, if they say, beta, that painful hemorrhoids will be seen in which condition? So you have to remember, beta, painful which is there, painful hemorrhoids will be only seen in either external hemorrhoids, beta, or in thrombosed hemorrhoids. What are thrombosed? That is the hemorrhoids which are blocked. Okay, so only two hemorrhoids of piles are going to be definitely, beta, painful. Either it is external piles or the thrombosed piles, beta. Those are going to be painful. No issues with this. Next important, beta, if they ask you on examination, what will be there? So please remember, beta, on examination, definitely when we do a DRE, okay, examination ke liye what we do? For examination, we have to go for a DRE, beta. What is DRE? Digital rectal examination. So our patient will lie in the lateral position facing towards the wall. The patient has to take the knees towards his chest and relax his perineal muscles. We have to insert our index finger into the patient's anal canal, and then we try to feel the mass, beta, right? So please remember, when we do a digital rectal examination, definitely, okay, on that digital rectal examination, beta, we try to feel the mass. We will always try to feel the mass over here, beta. Now, please remember, beta, we can actually assess with the help of a DRE or the investigation that we'll do next, known as proctoscopy, beta, whether the hemorrhoids are going to be primary or secondary hemorrhoids, beta. Okay? Now, if I talk about the primary hemorrhoids or secondary hemorrhoids, what is the difference? Understand. We know, beta, okay, we have to consider that the anal canal which is there, beta, it is a clock. If I consider that the anal canal is a clock, beta, then if there is any hemorrhoid, beta, at 3 o'clock, 7 o'clock or 11 o'clock position, okay, if there will be any hemorrhoid at 3 o'clock, 7 o'clock and 11 o'clock position, beta, then these will be called as primary hemorrhoids. That has been a question in your exam. Yaad rakhna, because these are the primary sites of the rectal vessels. And if there is any hemorrhoid anywhere else, beta, these all will be called as secondary hemorrhoids. Clear about? So primary hemorrhoids are seen at which position? Do remember, primary hemorrhoids will be seen at 3, 7 or 11 o'clock position, beta. Okay, at 3, 7 and 11 o'clock position, if you are able to get any hemorrhoid, that is a primary hemorrhoid, which is. If the hemorrhoid is anywhere else, beta, then it will be considered as a secondary hemorrhoid. Okay, anywhere else, it will be considered as secondary hemorrhoids. So here you are able to see, beta, this is the hemorrhoid, this is the dilated vessel that you are able to see, beta. These are going to form a mass. These are the hemorrhoids. Here also, beta, you are able to see a thrombosed hemorrhoids. It is appearing blue, not completely. That means definitely the hemorrhoid is getting blocked and it is cyanosed, therefore it is a case of a thrombosed hemorrhoids. No issues with this. Next important, beta, if I talk about what is the investigation of choice. So yaad rakhna, beta, the investigation of choice, if they ask you, answer has to be a proctoscopy. I've shown you the proctoscope, right? It is used for the examination of rectum. So you have to insert the proctoscope, beta, and with the help of a light source, you have to examine the rectum. You'll be able to see these hemorrhoidal masses, beta, on the proctoscopic examination. The investigation of choice is no radiological investigation beta, just a proctoscope is enough to make a diagnosis of hemorrhoids. Now we have to actually classify the hemorrhoids into 4 grades beta. Now what are the 4 grades of hemorrhoid? Just first listen to me and then we will see the grades. याद रख लो. Grade 1 hemorrhoids beta मतलब the patient says, Doctor साहब, I'm only having bleeding per rectum. There is no mass coming outside. ठीक है. So अगर वो बोलता है कि बस खून आ रहा है, कोई mass नहीं है. That is what is grade 1. Grade 2 means beta, he says, Doctor साहब, I'm having bleeding. Along with that, whenever I go for defecation or whenever I go for passing stools, I apply pressure, and on applying pressure or on straining, a mass comes outside. But as soon as I release the pressure, the mass goes back on its own. Okay. वो बोलता है कि जब भी डॉक्टर साहब डेफिनेटली आई गो टू पास टूल्स, ठीक है, प्रेशर लगाने पे मास बाहर आता है बट वो अपने आप वापस चला जाता है. दैट मींस द मास इज शोइंग अ स्पॉन्टेनियस रिडक्शन ओवर हियर. दैट इज ग्रेड 2. Grade 3, he says, Doctor साहब, I am having bleeding. A mass also comes outside whenever I strain. But once that mass comes outside, it does not go back on its own. Yes, I have to push back the mass with the help of my fingers. वो बोलता है कि डेफिनेटली when he is passing stools बेटा, a mass comes outside, but जो mass बाहर आता है बेटा वो वापस अपने आप नहीं जाता, उसको लगा पीछे ढकेलना पड़ता है with the fingers. This is called as a grade 3 beta, where there is a manual reduction required. And grade 4, he says, Doctor साहब, the mass is always hanging outside, the mass is always prolapsed outside. Clear है बात? So grade 1 of hemorrhoids, grade 1 hemorrhoids which are there beta, you have to remember grade 1 hemorrhoids में there is only bleeding beta, there is no prolapse of mass which is seen. Grade 2 hemorrhoids में beta, they will see definitely the mass which is there, it prolapses on straining beta, but it shows a spontaneous reduction. Grade 3 hemorrhoids में beta, you have to remember that the mass prolapses on straining again, but a manual reduction is required. And grade 4 hemorrhoids में he will say that the mass is always prolapsed outside. Clear all of you now? Next important, if they ask you about the treatment beta. So do remember, if they ask what is the treatment in the patient of a hemorrhoids beta, so the common advice that you should give to all the patients of hemorrhoids beta should be lifestyle modifications, right? Lifestyle modifications beta should be common to all the grades of hemorrhoids. Does not matter, irrespective of the grades, in all patients of hemorrhoids beta, the lifestyle modification should be advised. Reason, the risk factor, that is constipation, is it modifiable? Yes. Okay. So for that beta, to prevent constipation in this patient, we should advise lifestyle modifications. And what are those? First, the patient should take a high fiber diet. And by high fiber diet, we don't mean aloo. We definitely mean beta the green leafy vegetables basically, right? Those green leafy vegetables or fresh fruits, they definitely have high fibers beta. Okay. So please remember high fiber diet. Second important beta, plenty of fluids basically. Okay, plenty of fluids when I say, okay, that is patient has to take a lot of water. Due to that beta, the stools of the patient will become softer and therefore there will be an easy passage of those stools. Next important, the patient has to avoid any fried fatty food beta or even meat for that matter. Reason, that fried fatty food or that meat has a longer transit time beta and therefore they increase the risk of constipation. Is area. Whereas if they ask you apart from this beta, the other advice can be sits bath. The patient has to take warm water in tub beta and the patient has to sit inside that warm water tub beta for some time. It is actually going to give pain relief if there is any pain, and it is actually going to relax the anal sphincters beta so that the patient is able to pass the stools easily. Next important beta, the patient can also be given stool softeners. That means even after trying all of that beta, the patient is still having constipation, so stool softeners or laxatives can be prescribed. Something like a syrup of lactulose or cremafin plus syrup that can be used. Now if they ask you beta the grade wise management, so first degree hemorrhoids, if there is if we have grade 1 of the first degree hemorrhoids, here only lifestyle modifications are advised beta. Here only lifestyle modifications are to be advised. No surgery has to be done. Clear to all of you? Second degree hemorrhoids beta. When I talk about a second degree hemorrhoids beta, you have to remember one thing. See, second degree hemorrhoids mein beta, you can see definitely we have applied rubber bands at the base of hemorrhoids. I have told you varices main, right? So here you have to go and apply the band at the base of hemorrhoids. Why? Because if you apply band at the base of hemorrhoids beta, the hemorrhoidal mass will not receive any blood supply, due to which either the mass is going to fall off or it is going to shrink in size. That is what you want. Okay? And if banding is done beta, still the patient is having the problem, then you can actually inject a sclerosing substance in the base of hemorrhoid. Why? Because once we inject a sclerosing substance at the base of hemorrhoid, again there will be fibrosis, which will actually cut off the blood supply of the hemorrhoid, and then the hemorrhoidal mass is going to shrink. That is what is done. That is known as a sclerotherapy. I've told you, always prefer banding over a sclerotherapy. Reason: banding is a safer procedure than sclerotherapy. So always try banding first. If that fails, then we go for a sclerotherapy. The most common sclerosing agent used, I've told you, it is known as 3% sodium tetradecyl sulfate. The grade 2 के लिए बेटा और second degree के लिए we can go for banding or sclerotherapy. Even laser nowadays can be tried. Next important beta is third or fourth degree. If I talk about the third or fourth degree hemorrhoids beta, third and fourth degree hemorrhoids के लिए we have to go for a surgery. In third or fourth degree hemorrhoids beta, we have to go for a surgery. Now, what are the indications of surgery? Let's see that. So if they say beta, what are the indications of surgery in patients of hemorrhoids? First is if it is either a third or fourth degree hemorrhoid, or even if it is a second degree hemorrhoids beta, but that patient is not responding to the treatment. That means you have tried banding, you have tried sclerotherapy, but still the patient is not responding. So if the grade 2 hemorrhoids is not responding to treatment, in those patients also we can go for a surgery. And lastly, if it is a thrombosed piles or a thrombosed hemorrhoids beta. Now, what is the surgery of choice nowadays? I've told you beta, the surgery of choice nowadays is going to be a surgery called as a stapler hemorrhoidopexy. Now, what we do in this surgery beta? In this surgery beta, we are going to use which kind of stapler? I've told you. We are going to use beta a circular stapler in this surgery. And with that circular stapler, what we do? We basically beta actually we actually cut and staple the hemorrhoidal mass at the same time, right? So circular stapler kya karta hai? It cuts the hemorrhoidal mass and immediately staples the base. As beta the stapler is going to cut and immediately staple beta, that's the reason definitely the chances of bleeding are going to be very minimal beta in a stapler hemorrhoidopexy. That's the reason nowadays it is preferred as the surgery of choice. Yeah, in clinical practice, more commonly in government hospitals, you may be able to see hemorrhoidectomy only. But yeah, better one was always a surgery mein stapler hemorrhoidopexy. Now, if they say beta, what is another surgical option? As I told you, hemorrhoidectomy beta. Now, hemorrhoidectomy means we have to remove the hemorrhoidal mass. ठीक है? अब अगर वो mass निकालना बेटा, if you have to remove the hemorrhoidal mass, we know that is a vascular mass, so it is going to bleed a lot. ठीक है? So removal of hemorrhoidal mass beta can be done by two ways. First is open hemorrhoidectomy. Open hemorrhoidectomy, as you are able to see beta, we are just going to remove the mass beta, and then we are just going to cauterize the base. We are going to remove the mass and we are just going to cauterize the base. That means we have kept the base open. Just to control the bleeding, we have cauterized it. This is called as an open hemorrhoidectomy beta, known as the Milligan-Morgan hemorrhoidectomy. Next important, here we have removed the hemorrhoidal mass, and then after that we have sutured the base beta. So if you are going to suture the base, that means you are closing it. This is called as a closed hemorrhoidectomy beta, also known as a Ferguson hemorrhoidectomy. Name has been asked in your exams earlier. So if they ask you beta, the open hemorrhoidectomy which is there. So as I've told you, the open hemorrhoidectomy is known as the Milligan-Morgan hemorrhoidectomy. The Milligan-Morgan surgery or the Milligan-Morgan hemorrhoidectomy beta. Whereas if I talk about the closed hemorrhoidectomy, the closed hemorrhoidectomy is known as the Ferguson surgery or the Ferguson approach. If they ask you what is going to be the most common complication of the surgery, so yaad rakhna, when we do a hemorrhoidectomy surgery, the most common complication of the surgery is again the same beta, like in rectal prolapse surgeries. Here we may damage beta the nerve supplying the bladder, and that's the reason definitely the bladder is not able to contract, and that's the reason the patient will have a severe urine retention. Right, the patient is going to have beta a severe urine retention. No issues with this. That is important. Apart from that beta, do remember that the patient may have chances of hemorrhage also, right? Obviously bleeding can be seen very commonly in hemorrhoidal surgeries beta. Nowadays due to hemorrhoidopexy it is less, but still hemorrhage or bleeding can be there. Patient may have pain. We are operating in the rectum beta or the anal canal. We can damage the anal sphincters, causing a fecal or an anal incontinence. There can be chances of stenosis in the anal canal, causing narrowing, or there can be chances of recurrence. Even after surgery, there can be a chance of recurrence if it is not properly operated. Clear? Hai? That was all about your hemorrhoids. The next condition that we are able to see beta over here is known as an anal fissure, also known as fissure in ano. Now, what is basically a fissure beta? Fissure in literal terms means a crack. Yes, So here basically beta there is actually a crack or a cut inside the anal canal. Yes, the anal canal which is there beta, it is breached. Why? For example, the patient was having chronic constipation and due to that there were hard stools beta. And as the patient was passing these hard stools beta, these hard stools have actually injured the anal epithelium beta. And due to that injury of the anal epithelium, the patient is having a crack in the posterior wall of the anal canal beta. This is what is called as an anal fissure or a fissure in ano. Clear about? So anal fissure is nothing else but breach in the continuity of epithelium. Breach in the continuity of anal epithelium beta, that is cut. Okay, most common site. If I consider beta the anal canal as a clock again, so as I told you beta, when the stools are getting passed, okay, these hard stools, they're actually going to cause beta this fissure in the posterior wall. And if I talk about a clock, that means they are actually going to cause beta the injury in the posterior midline. That is at which clock position? 6 o'clock position. The most common site for anal fissure beta, the most common site for anal fissure is the posterior midline of the anal canal. And when I say posterior midline of the anal canal, that means we are actually saying at 6 o'clock position beta. It is usually at the 6 o'clock position. Hopefully that's clear to all of you. The most common site is going to be the posterior midline or the 6 o'clock position. No issues with this. It can also occur in the anterior midline beta at 12 o'clock position. You will be like, sir, how? In the anterior midline or in the anterior wall of the anal canal also beta at the 12 o'clock position it can happen. Reason? For example, the female had a obstructed labor. Now as the female had a obstructed labor beta, the baby's head was lying inside the vagina. We know vagina is anterior to the rectum. So beta, the baby's head was actually lying inside the vagina for a very long duration of time. And the baby's head was pressing against the anterior wall of the anal canal. And as the baby's head was pressing over here beta, the anterior wall of the anal canal was not receiving enough blood supply. Therefore, it undergone a necrosis and that led to formation of a fissure in the anterior midline. Clear about? So if they ask you what are the risk factors beta, one risk factor I've already told you, extremely hard stools due to constipation. Okay, this is actually a common risk factor. Other risk factor can definitely beta the ischemic necrosis due to a prolonged vaginal delivery or an obstructed vaginal delivery. Clear? If they ask you what will be the clinical features, so do remember beta, the patient is going to have a proper history of constipation. The patient is actually going to have beta constipation. Okay, so constipation ki history is seen in two conditions. One definitely beta is a hemorrhoid. Second is anal fissure. And यहाँ पे beta you will be able to see this is what is anal fissure. Can you see this one that you are able to see now? This is anal fissure. Okay. So beta here the patient is going to have bleeding from this fissure, but that bleeding is not so much like a hemorrhoid. Here just there is a line of blood beta or a streak of blood seen on the stools. Okay. So please remember beta, the patient is going to have painful beta. In hemorrhoids it was painless. Here there will be extremely painful bleeding beta. Yes, extremely painful. Bleeding is very less, but the pain is very much. The patient will have beta painful bleeding per rectum. And that bleeding per rectum which is there beta in patient of anal fissure is described as what? That bleeding which is there beta, it is usually described as a posterior streak of blood, or you can just say streak of blood. There will be a streak of blood which will be seen on the stools. Okay? So please remember beta, there will be a painful bleeding per rectum in a patient of anal fissure. If they ask you if there is a chronic anal fissure beta, and if you are examining that chronic anal fissure, on the examination of chronic anal fissure, what will be seen? So on the examination of chronic anal fissure, can you see this tissue over here? This tissue which is there beta, it is called as the sentinel skin tag. So yaad rakhna, whenever there is a chronic anal fissure beta, you will be able to see this tissue collected over there, and this is classically called as the sentinel skin tag. So in patients of chronic anal fissure beta, we are able to see a sentinel skin tag which will be present. Okay? Next important, if they ask you what is the investigation of choice, I hope you quite remember that a digital rectal examination or a proctoscopy would be absolutely contraindicated beta in patients who are suffering from anal fissure. Reason beta, if you do a proctoscopy or a digital rectal examination, they are going to kick you so hard, as I've told you, that you remember it for lifetime. Okay? याद रखना बेटा, it is absolutely contraindicated because the patient has so much of pain. The patient is not even going to let you touch him. So therefore, definitely DRE and proctoscopy both are absolutely contraindicated. Beta. So what is the investigation of choice then? Investigation of choice is nothing else but beta, separate the buttocks of the patient and just do an external inspection. That's it. Okay? So investigation of choice is nothing else but an external inspection. And on that external inspection itself, beta, you are able to see there is a fissure or a cut in the anal epithelium, and you are able to see a sentinel skin tag if, okay, if definitely it is a chronic one. Now, what should be the management, beta? So management, you have to remember, beta, you have to go for lifestyle modifications or the lifestyle changes. As the risk factor in hemorrhoids and anal fissure is going to be the same. Obviously, beta, the lifestyle modifications or the changes are going to be the same exactly. Right? Here also you have to prevent constipation in the patient because that is the main reason. So you will advise again the patient to take high fiber diet. You will advise the patient to take plenty of fluids to make the stool softer. And please remember, beta, the patient should be avoiding fried fatty food as well as meat. Okay. If they ask you, beta, what are the other advices to be given? So obviously you have to ask, beta, the patient to take stool softeners. Okay, if only lifestyle modifications are not helping. Okay, allow stool softeners or laxatives like lactulose or cremafin plus, and the patient will take sitz bath. Do remember, beta, that in a patient of hemorrhoids, maybe sitz bath may not have a proper or enough role. याद रखना in a patient of anal fissure beta, sitz bath will have a very important role. Why? Because the patient will take warm water in a tub and then he will sit over there beta. That warm water is actually going to give him some pain relief. Secondly, that warm water is actually going to relax his anal sphincters so that he can pass the stools easily beta without pain or with less pain. Okay, so sitz bath will have a very important role in the management of anal fissure. Do remember, apart from that, as the patient has a lot of pain, you can also give beta sorry, some painkillers or analgesics for the local application. You can give some ointments or gels beta. So you can actually advise the patient some gels for the local application. That is, you can advise a 2% xylocaine or a lignocaine jelly beta. Okay, 2% lignocaine or xylocaine jelly can be prescribed. Or beta, we can also give some diltiazem ointment. Diltiazem is a calcium channel blocker, which will definitely relax the smooth muscles over there. So diltiazem ointment can be prescribed, or definitely a nitrate gel. Nitrate gel may be having a side effect like headache, so it's better to go for xylocaine jelly or a diltiazem ointment. If they ask you, beta, what is going to be the surgery of choice now? So please remember, beta, here what we do in surgery, here we actually go inside the anal canal, beta, and we cut the anal sphincters. Yes, we actually make an incision over the anal sphincter, but that incision or the cuts over the anal sphincter should be only superficial beta. Okay, why? Because if you make the cuts over the anal sphincters which are somewhat superficial, these anal sphincters are going to somewhat relax and then the patients can pass the stools easily. But if you make the incisions beta much deeper, if you actually cut the whole anal sphincter, then the anal sphincter will get completely damaged and there will be no control over the anal canal, and that's the reason the patient will have a continuous leakage, that is anal incontinence can develop. So that's the reason surgery is usually avoided in this patient, because the surgery has a very important complication. If they ask you what is the surgery for this patient, that surgery when we make multiple cuts or the incisions of the anal sphincter laterally is known as a lateral anal sphincterotomy. That surgery which we do beta can be called as a lateral anal sphincterotomy. No issues with this. If they ask you beta what is going to be the complication of the surgery, so do remember beta the complication of the surgery, okay, the complication of surgery in the patient is going to be a anal or a fecal incontinence. I told you that can be a major complication beta. The patient can actually have an anal or a fecal incontinence. Right, that is important. And we will discuss one more topic today, then we are done with GIT. Appendix would be left definitely, but the anal canal tak सब कुछ हो जाएगा. And that is perianal fistula beta. This is the last topic from here. Now, if I talk about perianal fistula beta, also known as fistulae nano. Now, what is that condition? Let's try to understand beta. See, once this is the anal canal of the patient beta, and this is the perianal skin. Now, beta, what happens over here is basically here we have a lot of anal glands, right? So, what has happened? The patient was having anal gland that has got infected. That means there was an anal sepsis or an anal gland infection. That has led to a lot of pus formation, matlab abscess, and that abscess ultimately ruptured. As that abscess ultimately ruptured beta, that pus has basically drained. But the problem is what now? There is a one-way connection with skin which has formed. One-way connection with skin which is there beta, it is known as a sinus. Now, this infection which is there beta, as it has spread outwards, it will also spread inwards beta. And as it will spread inwards beta, here also it will actually make a connection with the anal canal. And as you can see, definitely now there is a connection with the anal canal also beta. This has led to formation of a perianal fistula, right? So on one side beta there is a connection with the anal canal, on another side beta there is a connection with the perianal skin basically. This is classically called as the perianal fistula or a fistula in ano. Clear about? Now please remember how to differentiate it from a sinus. Reason, sinus mein beta the pus will be draining only from the sinus opening, but in a case of a perianal fistula beta the pus will surely come out from this opening, but mainly and the most important one, the pus will come out from the anal canal or the rectum beta. If the pus discharge is seen per rectum, it has to be a case of a perianal fistula. That is suggested. That means there is a connection with the anal canal somewhere. Clear about? That is important. Pus discharge per rectum is suggestive of a perianal fistula in a patient. Right? Understood? So please remember, beta, I have told you perianal fistula, which is there, also known as fistula in ano. Okay. This condition usually beta it occurs secondary to a case of sepsis. Okay. It occurs secondary to a case of an anal sepsis beta. Here we had at the dentate line beta, there is infection of the anal glands, and as there is infection of the anal glands beta, that leads to formation of a perianal abscess. As I've told you, that abscess which is there beta, it shows a spontaneous rupture, and due to spontaneous rupture of the abscess beta, on one side it gets connected with the perianal skin, on another side it gets connected with the anal canal, leading to formation of a perianal fistula. Clear to all of you? Clinical feature if they ask you beta. So please remember beta, in this patient, the clinical feature, as I've told you, the patient is actually going to have beta a pus discharge per rectum. The patient is actually going to have beta a pus discharge per rectum. That is very classical. And due to this pus discharge beta from the rectum and from the opening basically, okay, the patient will also have staining of the undergarments, right? Due to that pus, definitely the undergarments of the patients are going to stain. There will be staining of undergarments by the pus. As there is infection over here beta in the surrounding area, obviously the patient is going to have experience a lot of perianal pain. Now, if a patient who is there beta, if a patient who is there, who is having multiple perianal fistulae beta, who is having multiple perianal fistulae, what is going to happen? From all these perianal fistulae beta, there will be discharge of pus, right? It will look like what? It will basically look like beta. You might have seen this water can that we use to water the plants in the garden beta. Right, from that how the water comes out, just like beta over here, the pus is going to come out from the patient's perianal region. Therefore, this perineum of the patient who has a multiple perianal fistula will be classically called as the water can perineum. Okay, if a patient has multiple perianal fistulae okay, it is classically called as the water can perineum beta. This has been another question of your exams. Okay, it is known as the water can perineum. Okay, so they actually asked that water can perineum is related to which among the following conditions. So answer was perianal fistula. Okay. Now important is beta, if you do an external inspection over here, the external inspection pe what we have to check? External inspection pe beta, we have to check the external opening of the perianal fistula. This one, we have to check the external opening of the fistula. Second, I have to insert the finger beta inside this fistula also. Okay, yes, I have to insert the finger inside that fistula to check definitely whether the track which is there, it is either a straight track or it is a curved track, and second, where is the internal opening. Okay, so definitely beta, when I do an external inspection pe I will definitely check the external opening, and along with the external opening beta, I have to also check the tract. I'm going to feel the tract beta. On external inspection, definitely we have to do two things beta. We have to first of all check the external opening, and second we have to feel the tract as well, whether it is straight or curved. Then we will go for a DRE beta, that is digital rectal examination. And when we go for a DRE beta, we have to check for what? On a digital rectal examination, when we go for, we have to check for this internal opening beta. ढूंढनी है तुम्हें internal opening का है. So on the digital rectal examination beta, we have to check the internal opening. Clear to all of you? That is important. Now beta, there is a Goodsall's rule that is usually followed beta for a perianal fistula. Now what does that Goodsall's rule says? That Goodsall's rule say beta that usually the anterior fistulas which are there, okay, the anterior fistulas which are there beta, you can see they will have a straight tract, whereas the posterior fistulas which are there, they will always have a curved tract, because they open anywhere but they will come and open in the midline in the anal canal beta. ठीक है, तो anal canal में वो उनका opening जो होता है, it is always in the midline for the posterior fistulas. ठीक है, so that is important beta. So the Goodsall's rule. This was another question that the anterior fistulas have a curve, straight track and the posterior fistulas have a curved track. It is explained by which among the following rules in perianal fistula? Answer was Goodsall's rule. Okay. So Goodsall's rule, which is there definitely beta, they will say that your anterior fistulas which are there, as I've told you, they have a straight track, whereas the posterior fistulas which are there, they will have a curved track. No issues with this, anybody? That is what the Goodsall's rule says in perianal fistula. Now, if I talk about the classification that is used for the perianal fistula beta, if I talk about the classification, so do remember beta, the name of the classification that is used for perianal fistula is known as the Parkes classification beta. Yes, that classification that is used beta for a perianal fistula is going to be called as the Parkes classification. And according to the Parkes classification, bache, the perianal fistula is classified into multiple types. Let's see them once. Remember the name of the classification, क्या बोलते हैं इसको? Parkes classification beta. According to the Parkes classification, it is classified into various types. The first one now, see, here I'm highlighting, attention. First one, we know beta, पहले तो ये देख लो that this is the dentate line, this is the anal verge of the opening, this is the anorectal ring over here. The purple one is the internal anal sphincter, the yellow one is the external anal sphincter. Now, please remember beta, this one which is there. Here you can see beta, the fistula which is there, it is very, very superficial. It is not even connected to the sphincter. So the first one is known as the superficial fistula beta. Second one you are able to see beta, it goes between the sphincters and then opens up. As the fistula is going between the sphincters and then opening, this is called as an intersphincteric fistula. And this is the most common type, which was the question again. Next, the third one which is there beta, it actually crosses both the sphincters and then it opens beta. This fistula beta is what is called as a transsphincteric fistula because it is crossing all the both the sphincters. Next beta, this one, the fourth one. Here beta, the fistula is going above the sphincter and then opening up. As the fistula goes above the sphincters beta, this is what is called as a suprasphincteric fistula. And this last one beta, you are able to see, this is not even connected to the sphincters. This is lying outside the sphincters beta, therefore this will be called as an extrasphincteric fistula. Right. Now important is beta, if they ask you which is the most common type, I've told you beta, the second which was seen. So this was a previous year question in FMG exam. The most common type of fistula beta is going to be called as the intersphincteric fistula. The most common type of fistula bache is going to be called as the intersphincteric fistula. Okay, the most common type of fistula is going to be an intersphincteric fistula. Clear about? Now, if they ask you beta, what is the investigation of choice? So do remember beta, the investigation of choice in this patient is basically MRI. I told you best investigation radiologically for perineum has to be the MRI. And beta, in this MRI, we actually do a T2 weighted MRI so that we are able to see the fistula properly. And beta, we are actually going to see the fistula. So therefore, beta, this type of MRI can be called as a MR fistulogram. A repeated सरकारी question of FMG exam beta. ठीक है, तो investigation of choice अगर वो पूछेंगे बेटा, it is usually a MR fistulogram. In previous year exams beta, one time definitely instead of writing MR fistulogram, they have written only MRI. One and the same thing ना भाई, ठीक है? So please remember MR fistulogram बोल लो या MRI बोल लो, it's one and the same thing. So that is going to be the investigation of choice beta in the patient of perianal fistula. Now lastly, if I talk about the treatment beta, do remember that we have to first of all classify the fistulas into two types for the purpose of treatment. Now what is this classification? Easy. Understand beta, if I say that this is the anorectal ring beta, any fistula that opens above the anorectal ring will be called as a high fistula. Any fistula above the anorectal ring which opens is known as a high fistula. Any fistula which opens below the anorectal ring is known as a low fistula. Now if I talk about the high fistulas first, what we do in high fistula, we actually insert a thread beta. Yes. What is this thread? This thread is known as a Seton thread. This Seton thread beta, as I insert inside the fistula, it is known to cause fibrosis of the fistula and therefore the fistulous tract is going to close. One thing. Or beta, if the fistulous tract doesn't close, we can actually tighten up this thread every time beta. Sorry. What is going to happen due to that? As we keep on tightening this thread basically beta, definitely you will be like, so won't the sphincters damage? Yes, the sphincters are going to damage, but beta, we do what? We tighten the fistula, we damage the sphincters. Again, those sphincters are going to repair in a span of 10 to 12 days. Again, we are going to tighten the fistula beta. Okay, so definitely tighten the thread beta. So here we are damaging the sphincters beta, but we are also giving them time for the repair. So here beta, we are actually doing a gradual damage to the sphincters so that the sphincters should not completely lose their function at once. Okay, still there is a risk of fecal incontinence. So that is the another thing beta that you can do definitely here. So this is what is called as a set-on thread insertion. Apart from that beta, if it is a low fistula mein there are two options. One is a fistulotomy, that is we will just cut open the fistula beta and we are just going to open up the fistula. As you are just going to open up the fistula beta, now there is no fistula left. Definitely now there is not a closed opening na. The fistula is opened up and therefore all the pus is going to properly drain, and now definitely there will be no collection of pus over here. That is called as a fistulotomy. This is a much safer surgery beta, because over here definitely the chances, okay, this is much a safer surgery beta, definitely because over here the chances of anal sphincter damage will be less. Other one which is there beta, here we have to remove the complete fistula, and if I have to excise the fistula completely, that is called as a fistulectomy beta. Fistulectomy mein definitely there are more chances of anal sphincter damage. Okay, so if they ask you beta, if what is the management, if the fistula is above the anorectal ring, if the fistula has an opening above the anorectal ring, that means when it is a high fistula. तो याद रखना बेटा, हाई फिस्टुला में the management is always set-on thread insertion. The management is always a set-on thread insertion beta. Whereas if the fistula is below the anorectal ring, if the fistula is below the anorectal ring, it is a low fistula, and in low fistula definitely beta, the management is what? As I've told you, fistulotomy is preferred over a fistulectomy. If they ask you which is the best surgery is fistulectomy beta. Chances of recurrence are very less, but sphincter damage के chances भी ज़्यादा है. Therefore, we commonly perform a fistulotomy beta, but the best surgery overall could be answered as fistulectomy. Clear baat? That was all about your perianal fistula. Okay, so tomorrow we'll start with appendix. Now please let me know in the chat box, those who are active basically, okay, what you want to start next tomorrow. Reason is beta, see, practically speaking, there will be some part of the surgery which will be left. Okay, most likely tomorrow either दो options दे रहा हूँ मैं. Tomorrow either I can complete urology part completely, or we can complete appendix, pancreas, liver, gallbladder, bile ducts and hernia. मतलब the pancreatic or hepatobiliary system along with hernia if possible mostly. ठीक है, so that can be done. तो मुझे दो options है तुम्हारे पास, either you have to complete urology or you have to complete the pancreatic or hepatobiliary system. ठीक है, please let me know in the chat box जल्दी से. So the other part which is left beta, we can complete it after Diwali. I'll let you know the exact timing. Okay, one class will be left, maybe half day or like around 7-hour class, 6 to 7-hour class. What you have to complete after tomorrow? Urology, ठीक है, no issues with that. Urology is any which way is important beta in the recent parts basically, and hernia if possible. Yeah, if hernia is possible, if urology is completed in time, we can go for hernia. If hernia, like it is not possible to complete hernia basically, then I can take hernia in the next class. Reason is I do not want to rush hernia. मतलब अगर बस 1 घंटे का टाइम बचा है, then I will not start the hernia tomorrow because in 1 hour it is not possible to take hernia. ठीक है, तो hernia के लिए at least 2 or 3 hours will be left. If 2 or 3 hours are left with me, I will definitely take hernia also tomorrow. No issues with that. ठीक है, अगर नहीं बचते तो let's see. So our target will be urology plus hernia tomorrow. ठीक है, चलो.